Okay, let's dive in. Today, we're cracking open a really important document. It's from the Indian Council of Medical Research, the ICMR.
Ah, yes, the 2023 guidelines on umbilical cord blood banking.
Exactly. You know, that whole decision parents sometimes face, saving the baby's cord blood right after birth.
It's definitely a topic with, well, huge scientific potential on one hand, but also, as these guidelines really highlight, some significant practical and ethical issues too.
Right. So our mission here is to kind of cut through the noise. We want you to really understand what cord blood is, what its proven uses are.
Versus what's still maybe just potential, yeah.
Precisely. And why these new guidelines were felt to be so necessary, and crucially, what you need to know, based squarely on the evidence in this ICMR report, to make an informed choice.
And, there are some surprising things in here, like the actual odds of using that stored blood,
Hmm.
and a really critical ethical point about the collection itself that the guidelines tackle head on.
Okay, so let's start right at the basics then. What exactly is umbilical cord blood? And why did scientists get interested in it in the first place?
So fundamentally, it's just the blood that's left in the placenta and the umbilical cord after the baby's born. For a long time, it was just discarded medical waste.
Right.
But then researchers found out it's incredibly rich in stem cells.
Ah, the stem cells, the sort of building block.
Exactly. Primarily, we're talking about hematopoietic stem cells, HSCs. These are the really powerful ones that can develop into all the different kinds of blood cells, red cells, white cells, platelets.
Okay.
It also has other types like mesenchymal cells, which are being looked at for other potential therapies, but that's more research stage.
And when did we first actually see this potentially used, like in practice?
The big turning point was 1988. That was the first successful transplant using cord blood stem cells performed in Paris for a child with Fanconi's anemia.
Wow, 1988.
Yeah, that really proved it could work as an alternative to bone marrow. And since then, the guidelines note there have been over 35,000 cord blood transplants done worldwide. It really gained traction.
Okay, so it's got a real track record in transplantation. What are the main sort of established conditions it's used for right now?
So the primary proven use is hematopoietic stem cell transplantation, HCT. That's the standard approach for certain blood cancers, some inherited metabolic disorders, and various genetic blood and immune system problems.
And the guidelines are pretty clear, aren't they? That in India, its current approved use is only for HCT for these specific conditions, following national HCT guidelines.
That's a really crucial point they make. Now, one of the big pluses of using cord blood for HCT, especially compared to bone marrow,
Ah.
is that the matching requirements, the HLA matching, it's less strict.
Oh, interesting. Why is that good?
Well, it's especially helpful for patients from diverse ethnic backgrounds. They often struggle to find a perfectly matched adult donor. So less stringent matching widens the pool. Plus, there tends to be a lower risk of graft versus host disease.
Okay. Are there other advantages mentioned?
Yeah, quite a few actually. The collection itself, totally non-invasive, no risk to the mom or the baby. It's usually quicker to process than bone marrow too.
Right.
Collection can be cheaper, lower risk of transmitting certain viruses, and again, that easier tissue matching is a really key benefit.
Those definitely sound like significant upsides. But you also mentioned limitations. What are the drawbacks the guidelines point out?
Yeah, there are definitely downsides. Engraftment, that's the time it takes for the new cells to sort of take hold and start working. That can be slower with cord blood.
Slower than bone marrow.
Generally, yes. And the number of stem cells you get from one cord blood unit's relatively small, which often means it's mostly suitable for children or smaller adults. You don't usually get enough cells for a larger adult patient from a single unit.
Right, that makes sense.
And it's a one-shot deal. You can't go back to the donor for more cells later if needed, unlike with bone marrow. And then there are, of course, the ongoing costs and technical aspects of keeping it stored properly long term.
So, okay, we have this resource. It's got proving uses, but also clear limitations. And this led to the whole idea of banking it, right? Could you explain that concept and the different models?
Sure. Cord blood banking is basically collecting and storing these stem cells for potential future use. And globally, as the guidelines discuss, there are really two main approaches: private banking and public banking.
Private banks. Those are the ones you tend to hear about more, the ones advertising.
That's usually the case, yeah. Private banks are typically commercial, for-profit companies. Parents pay a fee, sometimes quite a significant one, to have their baby's cord blood collected and stored.
And it's stored just for them.
Exactly. It's reserved exclusively for that child or potentially other close family members. It's not available on any public registry for someone else who might need it.
Okay. And public banks, how do they differ?
Totally different model. Public banks operate on altruistic donation. Parents choose to donate the cord blood free of charge.
Ah, like donating blood.
Precisely. The unit is then processed, tested, and if it meets the quality standards, it's listed anonymously on national or international registries. Then any patient anywhere in the world who needs a transplant and is a match can potentially receive that unit.
And the donor family doesn't own it anymore.
No, they relinquish ownership, they don't pay fees, but they also don't have exclusive rights. Though sometimes they might get some priority if, down the line, a family member needed a unit and their donated one was still available and suitable.
And the guidelines make a specific point about India here, don't they? That currently only private banks are operating.
That's right. As of the time of these guidelines, India had 22 licensed private UCB banks regulated by the CDSCO under the Drugs and Cosmetics Act. No functional public banks yet.
Oh.
And they also mentioned that, internationally, cord blood banking is regulated pretty much everywhere, FDA in the US, TGA, Australia, and so on, often with a mix of public and private systems.
Okay, so India had regulations, the Drugs and Cosmetics Act. Why then did the ICMR decide it was so important to issue these new, very detailed guidelines in 2023? What was missing?
That really gets to the core of it. While the Act provided the licensing framework, it just didn't have enough detail on, well, two critical things: the quality standards throughout the process, and maybe even more importantly, the ethical considerations.
So even with the existing rules, what specific problems were actually happening that pushed the ICMR to create this document?
They flagged several key issues. One was that not all the units being collected and banked were actually meeting the necessary quality criteria for storage or potential use.
Like what? Too small a volume.
Yeah, sometimes insufficient volume, or the cell count, the number of viable stem cells, was just too low.
So parents could be paying for storage of something that might not even be usable down the line.
That was a definite concern due to lack of detailed minimum standards. Another huge issue the guidelines hit hard is the marketing by some private banks.
Ah, the biological insurance thing.
Exactly. The report explicitly says that marketing cord blood banking as biological insurance for a whole laundry list of potential future diseases is simply not supported by the current scientific evidence.
That sounds, quite misleading if the evidence isn't there.
It can be. The guidelines mention persuasive language, sometimes even celebrity endorsements, framing it as this once-in-a-lifetime opportunity you can't miss.
Creating pressure, maybe?
Potentially creating unrealistic expectations or pressure, yes.
Yeah.
Plus, there was just a general lack of awareness sometimes, even among doctors, about which conditions cord blood HCT is actually proven and approved for, which is a fairly limited list, remember.
Okay, and here's a point that seems really significant, ethically speaking. The guidelines raise a direct conflict related to the collection itself, right? About clamping the cord.
Yes, this is a major ethical concern, a real red flag the ICMR raises. The issue is to get the maximum volume of cord blood for banking. There can be an incentive or pressure to clamp the umbilical cord really quickly after birth, early clamping.
Okay, but isn't there guidance on when to clamp the cord?
Yes. And that's the conflict. National health guidelines in India, like the India Newborn Action Plan, strongly recommend delayed cord clamping, waiting at least a minute, sometimes longer.
Why? What's the benefit of waiting?
It allows more blood to transfer from the placenta to the baby, which is really important for the baby's health. It significantly helps prevent iron deficiency and anemia in infants.
Right. So what do the ICMR guidelines say about this clash?
They are unequivocal. They state clearly that performing early cord clamping solely for the purpose of collecting a larger volume of cord blood for banking is unethical. Infant health comes first.
Wait, let me get this straight. The guideline is saying, do not compromise the baby's immediate proven health benefit from delayed clamping just to get more blood for potential maybe never use storage. That feels huge.
It is huge. It's a very clear prioritization. And adding to the why these guidelines were needed pile is the point about utilization, the actual use of privately banked cord blood.
How often is it used?
It's incredibly low. The guidelines cite global studies showing utilization rates for the original donor for self-use or autologous use as low as 0.005% to 0.04% over the first couple of decades. Tiny numbers.
Wow.
0.04%.
And in India specifically, they looked at registry data. From 2012 to 2020, across all those private banks, only 60 transplants using unrelated units, not for the original family, were recorded.
650 in 8 years.
Yeah.
From all the banks combined, that number is much lower than I would have guessed.
It really starkly illustrates the gap between the marketed idea and the reality of clinical use, especially for the family who stored it. Plus, the guidelines also remind us if a child has a genetic condition.
Right. Storing their own cord blood usually isn't helpful because those stem cells carry the same genetic defect. You wouldn't transplant the problem back into them.
Okay, so putting it all together, the ICMR basically saw a need for much more specific rules on quality, a direct pushback against potentially misleading marketing, and clear ethical lines, especially around protecting the baby during collection and ensuring parents really understand what they're signing up for.
Precisely. The guidelines aim to provide that necessary depth, specificity, and ethical clarity that maybe wasn't fully detailed in the broader regulations before.
Okay, so let's walk through some of the key practical guidance points in this document. What do they actually mandate now for, say, quality and ethics in practice?
They cover the whole chain, really, starting with donor management. This means thorough evaluation of both the mother and the infant.
What kind of evaluation?
Medical history, family history, any genetic conditions. It's all about assessing risk and protecting any potential future recipient.
And testing for diseases.
Absolutely. Mandatory screening of the mother's blood is required. They test for a whole panel: HIV, hepatitis B, hepatitis C, HTLV, CMV, malaria, syphilis.
When does that have to happen?
It has to be done close to the delivery within 7 days before or 7 days after. They also need detailed history on lifestyle factors, travel things, CJD, risk, any recent tattoos or procedures, current or recent infections. It's quite comprehensive.
Okay, then there's consent. Always a huge part of medical ethics. What's the guidance on informed consent for UCB banking?
This is critical, and they've added important specifics. Consent absolutely must be obtained before the mother goes into labor, ideally during the 3rd trimester.
Not doing labor itself.
Definitely not. The idea is to avoid decisions made under stress or duress. It has to be fully voluntary, truly informed, and everything needs to be explained in a language the mother clearly understands.
And they added a specific point about translation, right?
Yes, a really interesting detail. Family members are explicitly not permitted to act as translators during the consent process.
Why is that?
To ensure the information is delivered accurately and without any potential bias or pressure from family. An impartial translator or staff member should be used if needed.
Okay. What information must be covered in that consent discussion?
The guidelines lay it out. Parents need to understand the basic purpose: storing HSCs for potential HCT. They need to hear the risks, the benefits, both medical and ethical. What are the alternatives? And crucially, the intent of the donation.
Intent meaning private versus public.
Exactly. Is this being stored privately just for your family's potential use? Or is it being donated publicly for anyone who might match? That distinction has to be crystal clear.
And if it is a public donation?
Then the guidelines state parents shouldn't be charged fees. And they need to understand they give up exclusive rights to that unit, though they might get priority access later, as we mentioned.
What else does consent cover?
Things like how reference samples will be stored and used, any potential future testing on the samples, the bank's policies for disposing of units that don't meet criteria or aren't used, and, importantly, what happens if the bank were to close down.
Okay, moving to the delivery room. The actual collection. How do the guidelines make sure that's done properly and ethically?
For the collection procedure, it must be done by trained, qualified staff, a registered medical practitioner, nurse, or other approved healthcare professional, using sterile, approved collection kits, following strict aseptic technique.
And the ethical part regarding the baby.
They double down on that. The guidelines state collection practices must not interfere with standard obstetric care or the immediate health needs of the mother and baby with the specific intention of getting a bigger volume.
So respecting delayed cord clamping comes first.
Absolutely, it has to. They also note collection should ideally be for uncomplicated full-term births, with more caution needed for premature babies or multiple births.
Right. Baby's immediate health is paramount. Okay, so blood is collected. What happens next? Transport.
Yes, transportation needs to maintain the unit's integrity. That means strict temperature control, maintaining the cold chain is vital, plus proper labeling and traceability so that unit can always be tracked.
And when it gets to the bank, processing and storage.
Yep, processing, storage, and release. Processing should happen reasonably quickly, ideally within 72 hours. The unit undergoes more tests after processing, checking viability, cell count again, checking for contamination.
And storage conditions.
Very specific. Stored in the vapor phase of liquid nitrogen at or below minus 150 degrees Celsius, with continuous temperature monitoring and alarm system.
Wow, that's cold.
Extremely. And there must be clear written procedures, standard operating procedures, or SOPs for everything, including criteria for discarding units that don't meet quality standards. And finally, rules for release verifying safety, potency, viability before it goes to a transplant center, again ensuring cold chain during transport.
This really brings us back to that whole issue of misleading advertising we talked about earlier. The guidelines specifically address publicity and advertisements, don't they?
They do. They point out that misleading ads can already be tackled under existing Indian laws. There's the Drugs and Magical Remedies Act and parts of the Drugs and Cosmetics Act, which actually prohibit making claims about curing certain diseases, including through stem cells unless specifically approved.
So there are laws already.
Yes, and the Advertising Standards Council of India, ACI, also plays a role in looking at advertising content and handling complaints.
So if someone, maybe a parent or a doctor, sees an ad they think is misleading, what can they do?
The guidelines suggest several avenues. Complaints about unethical practices by banks can go to the CDSCO, either the zonal offices or the central body, or even to the ICMR itself. For misleading ads specifically, complaints can be lodged with ACI or potentially through consumer courts.
Okay, so there are ways to flag problems. Beyond just enforcement, though, what do the guidelines say about getting accurate information out there proactively?
They put a really strong emphasis on education and awareness for everyone involved.
Meaning parents.
Yes, expectant parents have a right to get clear, unbiased information about the different options, public donation versus private storage, about the real usefulness, but also the significant limitations of private banking, and the importance of voluntary donation for the public good.
And it's not just parents, right?
No, it's a shared responsibility. Policymakers, regulators, doctors, nurses, the banks themselves, everyone has a role in promoting awareness based strictly on the scientific facts.
How do they suggest doing that?
Things like public awareness campaigns, using media responsibly, providing ongoing education for healthcare professionals so they're up to date, and even integrating these topics, the science, the ethics, the regulations, into medical and nursing school curricula.
Okay, so let's boil this all down. What does this mean for you, the listener? Maybe you're expecting a child or you're a healthcare professional advising families. How does this impact decisions around cord blood banking?
Well, it really means that making a genuinely informed choice here requires looking past the hype or the marketing slogans. You need to understand the actual proven medical uses, which is primarily HCT for a specific list of conditions.
Not biological insurance for everything.
Exactly. You need to grasp the fundamental difference between donating to a public bank where it helps anyone who matches versus paying for private storage, which has a very low odds of being used by your own family for most of the claimed uses.
And understanding the ethical side, too.
Definitely. Understanding the ethical considerations the ICMR raises, especially about prioritizing your baby's immediate health needs, like delayed cord clamping over maximizing collection volume, and knowing that there is a regulatory framework trying to ensure quality and ethical practice, but awareness is still absolutely key.
So the most crucial first step sounds like getting unbiased factual information.
Absolutely. The guidelines push for healthcare providers to give this information clearly, fairly, disclosing any potential conflicts of interest they might have, like links to private banks, and making sure that consent, if given, is truly informed and obtained well before the pressures of labor start.
This has been a really illuminating deep dive into these ICMR guidelines. It's clear that cord blood is a valuable resource. It has proven uses in HCT.
But there's a big difference between those established uses and some of the broader claims.
Right. And these guidelines seem like a vital step. They add much-needed detail and quality. They demand ethical practices, especially putting the baby first during collection, and they take a firm stance against misleading promotion.
It really brings home the need for decisions in this area to be based on solid evidence and careful ethical thought by everyone involved, parents and professionals alike.
So maybe we can leave you with this question to think about, drawing directly from what we've discussed based on these guidelines. Considering the real potential of cord blood stem cells, but also the very low actual use of privately stored units for the donor family, and the ethical mandate from ICMR to prioritize the newborn's health during collection. How might the whole system of cord blood banking need to evolve? How could we maximize its public health benefits while still ensuring every family gets transparent, unbiased information to make a truly informed choice?
Understanding what these guidelines actually say is really the essential first step for anyone facing this decision or involved in providing care.
Absolutely. We really encourage you to seek out that unbiased information and get the full picture that these ICMR guidelines provide.